Good morning, Jahazib.
Yes.
Ah, lovely to hear from you. We're just starting the second session, and we'll probably request you to come as the second speaker because Dr. Pervez had some problems with his slides. So,
Okay.
okay, so we will start. Hi, Shahina. So good to see you. I think we're not able to get in touch with Dr. Azmina. I hope she's all right because it's not like her. So we just finished with our first session. A very warm welcome to all of you as well as all the audience. That I find a bit disturbing that I'm not able to see all the audience and the people watching us. But I can assure you there are quite a few of them, and hopefully there'll be more joining in. So, the first session we talked about HER2 positive and endocrine positive disease. And now we will be starting with the surgeons first. And I'm really pleased to introduce to everybody Professor Stefan Grobmeier. He's been the chief of surgery at Cleveland Clinic, Ohio, and currently he's at Cleveland Clinic, Abu Dhabi. He's published extensively, and if you want to see the best doctor in America, he's one of them, and he's been having that title since 2007. So I think we'll need a separate session from him how to become the best doctor of US. That's big. That's really big. So I'm really, really happy to introduce Professor Grobmeier, and he's going to talk to us about surgical therapies and de-escalation and how surgery has evolved and what is the current status in 2020. So thank you, Professor.
I'm Stephen Grobmeier from Abu Dhabi and Oncology Institute at Cleveland Clinic, Abu Dhabi. And it's a distinct honor to participate in this prestigious symposium. I'm going to talk today about some of the evidence-based trends in the de-escalation of breast and axillary surgery in the next 20 minutes. These are my disclosures. I'd like to begin by reminding you that breast surgery is rapidly evolving. And it was back in the early 1900s that we had radical mastectomy. It took over 60 years to develop modified radical mastectomy. And in the last 20 years, there's really been a very big proliferation of changes in our approach to the treatment of breast cancer as it relates to surgery and how we combine surgery with other modalities to improve the care and reduce the morbidity of the treatment that we provide to patients. So I'm going to begin with a definition of what I mean by de-escalation. And that's shown on the left side of the slide, but what I'm referring to is a reduction in the extent of surgical treatment without an impact on oncologic outcomes. This results in less morbidity and reduced cost. I'm also going to include within the definition of de-escalation surgery that new types of surgery that we've been working on that can be used to restore function and sensation following the extirpation of breast cancer. The evidence-based de-escalation is primarily resulted from two factors. One is the better understanding of the biology of breast cancer, and two is a better understanding of the impact other therapies have on outcome as they relate to surgical procedures for breast cancer. And then finally, as I will show you, there have been major improvements in surgical techniques, which are also allowing us in new ways to essentially de-escalate breast cancer surgery and reduce the side effects of a surgical treatment. My hypothesis for this lecture is that scientific and clinical evidence have and will in the future continue to de-escalate the surgical treatment of breast cancer. So this is kind of a broad overview of where surgical de-escalation is happening. I don't have time in this lecture to cover all of these areas. I will touch on a few, but they relate to lumpectomy margins, lumpectomy for multicentric breast cancer, repeat lumpectomy for in-breast recurrence, nipple-sparing mastectomy for invasive breast cancer, which in the United States was developed in Ohio at Cleveland Clinic in the early 2000s. I will touch also on the very hot area of axillary management with particular comment on the neoadjuvant setting, where I think there's most controversy and where in my practice in Abu Dhabi, I see the most questions and controversial questions. And then I will incorporate into this some of the future exciting directions that we've been working on as an international group to, as I mentioned, reduce the morbidity or essentially de-escalate in another way the surgical treatment of breast cancer. So I'll begin by talking about margins. I really think this is a major form of de-escalation that has had a major impact across North America and certainly around the world. When we were in training, and traditionally we used 2 millimeters for invasive breast cancer, and we were taught initially this was required to achieve optimal local control. However, the literature is replete with reports of re-excision rates of 20 to 50% or even higher, and this is really unacceptable for patients and extremely costly to the system. So in 2014, it was a consensus group brought together by Monica Morrow and colleagues, and they basically concluded in this meta-analysis that no tumor on ink was equivalent to wider margins. And this is our current practice, and it's been accepted widely by the SSO, American Society of Breast Surgeons, ASCO, and ASTRO. And if it's not incorporated into your practice, it's something that should be. This, as I mentioned, has led to major reductions in the need for repeat lumpectomy. This is a very current paper just recently published by Monica Morrow's team, which was a meta-analysis looking at the impact of the margin guidelines on the need for reoperation following lumpectomy. And this slide at the top looks at studies which had pre-guideline margins of greater than 2 millimeters, and you see a significant and clinically important reduction in the need for reoperation. And at the bottom, when one has a pre-guideline margin of 1 millimeter, there is still a reduction in the need for re-excision, albeit as expected, less. But this really has become part of the mainstay of our practice, and I really believe this has had a major impact on the care of patients. Another very interesting area is the role or potential role of lumpectomy in patients with multicentric breast cancer. We were certainly traditionally taught that patients who presented with multicentric disease required mastectomy, and that is still the practice many places. But there is now new data and new ideas about other options for the management of these types of patients. There have been a number of selected series of breast conserving therapy for multicentric breast cancer. I've highlighted 3 of them on the left side of the slide, and you see with follow-up of 6, 5, and 10 years, very acceptable local recurrence rates in patients receiving multiple lumpectomy followed by radiation therapy. And it was this type of data that led the St. Gallen International Consensus Conference in 2017. The panel strongly endorsed BCT for multicentric and multifocal disease, provided surgical margins were negative. However, not everyone is convinced of the available data, and there are some ongoing trials which we should be paying attention to. One is the Miami trial in the UK, which is a randomized trial of patients with multicentric breast cancer. This trial is ongoing. The other trial done in the United States is the Alliance trial, which is shown on the right side of the slide. This study has completed accrual, and as I will show you, we're starting to get some data, particularly as it relates to cosmesis in this population. But this was almost 200 patients enrolled on this trial, and the oncologic outcomes are still accruing, and we await those results. Very recently, however, the group did publish the initial analysis of the cosmetic results for patients having multiple lumpectomy followed by radiation therapy. And 71% of patients reported good or excellent cosmetic results using the BreastQ satisfaction score, which is very similar to patients having a single lumpectomy. And only 3.7% of patients had a poor cosmetic result. And importantly, there were no difference in outcomes when stratified by age, number of lesions, number of incisions, or size of the largest lesion. So I think for motivated patients in the right environment, this is an option to discuss with patients. Another area which is changing rapidly is the management or surgical management of patients with ipsilateral breast tumor recurrence following breast conserving therapy. Traditionally, we were taught, and we up until very recently taught residents that the only option for these patients was mastectomy. However, we do know that reconstruction in these patients is a challenge, particularly in those who've had prior chest wall irradiation. Shown on the right side of the slide is an example of an in-breast recurrence following lumpectomy. We're started now to accrue some data looking at other options. Shown on the left side of the slide is a series from Japan, which is a matched analysis comparing patients, 51 patients who had a repeat lumpectomy, comparing those who had mastectomy. And in both the distant disease-free survival and overall survival, there really is no statistically significant difference, which would suggest this is a possible option for, again, highly motivated patients and a definite change from our traditional practice. My colleague at main campus in Cleveland, the head of breast radiation oncology there, Dr. Chirag Shah, also has performed an analysis of multiple series of repeat lumpectomy followed by reirradiation. And the data for that is shown on the right side of the slide. And you will see very, I think, acceptable rates of local control using this type of approach. We now have data from a phase 2 trial performed in the US, the RTOG-1014 trial, which looks at, in a formal way, repeat breast conserving therapy after ipsilateral breast tumor recurrence. We've started to see initial reports very recently of this data as well. They reported 65 patients. All tumors were less than 2 centimeters. The recurrent tumors were less than 2 centimeters. All were clinically node negative. All patients in this phase 2 trial had repeat lumpectomy, followed by partial breast irradiation with the prescription shown on the slide. Median follow-up now is 5.5 years. They reported no grade 4 or 5 toxicity and a very favorable 5-year in-breast recurrence rate of only 5%. I would note that in this series of 65 patients, 7 patients required mastectomy for the reasons shown, which is not unexpected. A few words about nipple-sparing mastectomy. I do think this is de-escalation, and I think done in an experienced center, this is a good option for many patients. It's de-escalation because it makes the surgery less disfiguring and certainly associated with improved quality of life in patients in whom this operation is a safe option. We have lots of data from our center and many other centers showing nipple-sparing mastectomy in properly selected patients with invasive breast cancer is safe. Some example of that data is from Barbara Smith, shown on the left side of the slide. And we're able to achieve excellent cosmetic results with nipple-sparing mastectomy, as shown on the right side of the slide. What's new is a program Rizal Johan and I started back in Cleveland several years ago in an effort to begin to restore sensory function to the nipple-areolar complex in the setting of implant-based reconstruction. And so this is something we've been working on now and have published several papers on. The long-term sensory data is still accruing, but our early results are promising. Shown on the slide is an example of how we do this. We're able, with loop magnification during the operation at the lateral aspect of the mastectomy, shown here, to find branches of the intercostal nerve. Shown here is a branch of the 4th intercostal nerve. We then do a nerve graft to the nipple-areolar complex, and we have done histologic staining to confirm the presence of nerve endings as targets for that nerve graft. And again, this work is ongoing, and I'll refer you to some of our recently published work on this exciting topic, and look forward in the future to continue to update you on the efficacy of this approach. I'm going to end talking about the axilla quickly. We definitely know that the need for axillary node dissection is decreasing, and we are definitely de-escalating axillary surgery. Shown on the left side of the slide is the type of axillary dissection we were all taught in residency and fellowship, but we know now that that's associated with high rates of lymphedema, sensory changes in the arm, chronic pain, and the symptoms and the severity is worse when multiple therapies like surgery and radiation and chemotherapy are combined. There's lots of data to support that. So we try now to minimize the amount of axillary surgery. And in the interest of time, I'm really only going to give you my high-level thoughts on management of the axilla in patients treated with neoadjuvant chemotherapy, which we are using more and more commonly these days. So for patients who are clinically in zero, our approach is to use a sentinel node biopsy after neoadjuvant therapy. It's very feasible. There's very high identification rates, and the false negative rates are very acceptable. And this is really a standard for those who had initially presented with clinical N0 disease. In those who present with clinical N1 disease, traditionally, axillary node dissection has been the standard of care. However, we have embraced recent trials showing sentinel lymph node biopsy as an option for these patients, particularly those with triple negative or HER2 positive disease. There have been 3 trials of sentinel node biopsy in clinical N1 patients. They're probably familiar to most in the audience. The trials are shown here. I have a summary of some of the important results here on this slide. And suffice it to say that when done by expert centers and sentinel lymph node biopsy is used following neoadjuvant therapy in patients who present with clinical axillary disease, that if done properly, the sentinel node biopsy can actually be very accurate. There's been also interest in developing the concept of targeted axillary dissection, which is an approach we use, where a clip is placed in the node at the time of before chemotherapy. And when we remove that node, we know it's very accurate in predicting the status of the remaining axillary tissue. So we do perform targeted axillary node dissection. And in summary, I would say, when we do these procedures, we do dual mapping, as most centers do who have experience with this. We mandate that 3 sentinel nodes at least are removed, and we aim to remove the clip node, because if we achieve these, we think the axillary staging is actually quite accurate in this setting. So in summary, after chemotherapy and we do the surgery, if there's no disease in the sentinel nodal tissue and there's no clinically suspicious node, then we avoid axillary node dissections. And in patients who have residual disease at the present time outside of a clinical trial, we perform standard of care axillary node dissection. There's new data looking at the impact of this type of approach on a large practice in the United States. This is recently published data from the Mayo Clinic, Judy Bowie's group, which basically shows on the left side of the slide that when you look from 2009 to 2019, the number of axillary node dissections performed de novo following neoadjuvant therapy has declined precipitously, as you would expect. And the number of patients having a sentinel node procedure, either with or without an axillary dissection, has risen significantly. And this is certainly reflective of our practice. Shown on the right side of the slide is some of the only data I am aware of, which was looked at the freedom from axillary recurrence using sentinel node only. It's again data from the Mayo Clinic in this recently published paper. And it shows at 3 years excellent local control rates. And I would say this is the most common question we get when we offer this approach to patients. But we do believe, when given in the setting of radiation therapy, that this approach is actually quite effective and does limit morbidity from the treatment. And then I'm going to touch lastly on a very exciting area that we've really been pushing forward, which is surgery to prevent lymphedema done at the time of axillary node dissection. We call this lymphedema prevention surgery. We've developed a huge experience with this in Cleveland, one of the early adopters in the world using this approach. I'll just show you how we do this. At the time of mastectomy, shown at the upper left, we actually inject isosulfan blue dye into the inner aspect of the left arm. Then we perform the axillary node dissection sharply with very careful attention to preserve 2 structures. One are the blue arm lymphatics, which you can easily find with loop magnification and experience doing this. We also make an effort, which is not traditionally done, to preserve small crossing veins, which become the recipient for the divided blue lymphatics. We then, at the end of the axillary node dissection, which is done otherwise in a standard fashion, although done sharply, we perform with the help of our super micro surgeons, Lymphatico-Venous bypass, and I'll show you how we do that. To do this, you need an operating environment under 1 millimeter because these vessels are very small. You need a super microscope shown here. You need super micro surgery set, and you need experienced microsurgeons who can work in this environment. You typically use 12-0 suture. For those surgeons on the call, you'll recognize this is not readily found on most operating room shelves, but you need a microscope that looks like this and instruments like this. I'll quickly show you an example of what it looks like after the node dissection is complete. This is a vision under the microscope, so I hope you can see it. These vessels are on the order of 1 millimeter, and they look huge here, but they're actually not. It's shown the blue here with the clip on it is a dilated lymphatic that we can find typically 4 or 5 of these coming from the arm. The microsurgeons then cannulate these vessels just as you would in perhaps a macro surgery, but then cannulated vessels are then sewn back together. The arm lymphatics are sewn to the preserved veins, and this is a lymphatico-venous anastomosis. And people question the functionality of these anastomoses, but with the help of fluorescence microscopy, we've now shown, I'll show you an example in the movie, but on the lower right of the slide, we're able to perform an injection of ICG during the surgery and actually show flow through these restored lymphatics through the lymphatico-venous anastomoses. Typically, we'll perform 3 or 4 of these in the setting when we're able to do it. The question always is, does it work? Well, we have a large series which we have reported. This is an example here of the ICG flowing through the anastomosis. It's been injected in the arm. And if you look on the movie, you'll see ICG white. Yeah, so you see it there flowing through the anastomosis, showing it's a patent anastomosis. So we've reported already and continue to accrue our experience. We recently, several months ago, reported an international meeting, our early experience with 106 patients who underwent axillary lymph node dissection and lymphatic preserving surgery, as I showed you. We compared them to a historical group of patients having an axillary node dissection shown in this column. And you'll note that they're very, very closely matched. But in the overall lymphedema rate, it was more than half of the rate of lymphedema that we saw compared to the traditional patients treated at our hospital. And at 2 years, again, 13% in the reconstruction group compared to 29, which would be very consistent with data in the literature. So we think this is an exciting path forward and look forward to continue to develop this as an option to de-escalate the effects of axillary surgery in breast cancer patients. So thank you very much for your attention. I look forward to the discussion session at the end of the session.
Thank you, Dr. Gomez. That was really impressive surgery. It made me want to become a surgeon. So I didn't realize surgery's become so sophisticated, so nice. So, and yes, I would very much want that please stay with us and we'll need you in the panel discussion. And now I will request, there's a bit of a change. Dr. Rahman had some problem with, like with his computer. So he'll be the last speaker. Professor Jahazib will be the next one. So I see Azmina, my co-moderator and chairperson.
Hello, how are you?
Hi.
Hi.
So, Azmina, good to see you. Yeah, now.
Nice to see you.
So, yeah, okay. So I think I'll introduce Professor Nazib. Almost everybody knows him. He's a famous medical oncologist started off from King Edward's Medical College. He's been a professor of medical oncology for several years. He's currently the founder of Florida Precision Research. Did I say it right?
Yes.
And Jahazib has given 900 plus lectures. I don't know how he managed, but that's something, very impressive, and more than 200 publications. And his main areas of interest are breast cancer and lung cancer. So today he's going to talk to us about molecular profiling of breast cancer in clinical practice. And before you start, from the previous session already we are getting questions. Some of our fellows, one is Dr. Chandumal, he's repeatedly asking that who are the patients with breast cancer who need to have NGS and endocrine positive also. So I think we will get all the answers from Dr. Jahazib today. So over to you, Jahazib. Thank you for waking up so early.
So let me start sharing my screen. Okay, well, it's an honor to be here, and thank you, Dr. Nilam Siddiqui, for the kind words. The way to get to 900 lectures or 200 publications is to continue to live and keep working. So I'm old. When you get old, you have more than when you are young. So that's the secret. I'll talk about molecular profiling of breast cancer and stick to concepts, because in this short amount of time, there's no time to go over hundreds of clinical trials that surround these concepts. So I'll stick just to the concepts. So when we say genetic, we are talking about hereditary, such as inheriting BRCA1 mutation, whether it's beta thalassemia trait or sickle cell, that's hereditary. When we say genomic, we are talking about the entire genome of a person or a tumor. We are looking for somatic mutations in a tumor as opposed to germline mutations that we are born with. Even at the time of Aristotle, cancer was described, but it was thought to be a disease of the organs. Then with the advent of the microscope, we understood that it's a disease of the cells. And at the turn of the century, when human genome got decoded, we now fully understand that it's a disease of the genome. And it occurs by mistakes made when DNA is being copied and recopied because one cell becomes 3 trillion cells that a human being has. So carcinogenic process is slow, spans over decades. It can be viruses, infections of various sorts, radiation, or mistakes in DNA copying that are random, or other carcinogens such as cigarette smoke. And those mistakes are often meaningless, but occasionally they are meaningful mistakes that end up with the growth signal to cells to continue to grow and proliferate and metastasize. So altered genes code for altered proteins, which then lead to altered pathways that lead to cancer. Another way to describe this concept is if DNA is the architect, when you build a building or a house, you have an architectural plan, but then somebody has to look at it and construct a building. So that somebody, call it a builder, a contractor, is the RNA. And the house that's built or the building that's built is the protein that has a function, such as an enzyme or a hormone in the body. Now we have these targets that are targeted by pathway blockers, usually small molecule tyrosine kinase inhibitors. So you see the examples of various altered genes on the left-hand side, and you see how in the last 15 years, there's been an explosion of compounds that are used as targeted therapies. We are aiming for maybe 700 compounds by the time we reach 2025. Right now, we already have several dozen compounds used in various diseases. So there are 4 types of basic genomic alterations driving tumor growth. And they can be base substitutions. An example is BRAF V600E, that's operational in melanoma as well as lung cancer. We have insertions and deletions. An example is EGFR exon 19 deletion, for which we have multiple tyrosine kinase inhibitors already available in the market for lung cancer. They can be copy number alterations, such as HER2 amplification, when you have extra copies of HER2 gene in the cells, and we have drugs to intervene there. Or they could be rearrangements, such as ALK fusion in lung cancer, which is found in about 4 to 7% of adenocarcinomas, and we have drugs there. At the bottom of the slide, you see various tests, such as immunohistochemistry, which looks at protein expression on the surface of the cells. So you have to know what you're looking for. You make a monoclonal antibody to that protein and add, let's say, a brown stain to that antibody, and under the microscope, you then start looking at cells for that brown stain on the cell membrane and call it 0 if you don't see any, and 1+ if you see a few cells, 2+ if you see more than 10% of cells completely surrounded, 3+ if 100% of cells are completely surrounded. But you have to know what you're looking for. FISH, or fluorescent in situ hybridization, is basically looking for a particular gene and making a probe and adding a fluorescent dye to it. If it's not fluorescent, just a color, it's KISH. If it's silver, it's SISH. So you get the idea, in situ hybridization with something added to it to be able to identify it under the microscope. And then in case of HER2, for example, if it's chromosome 17 that has HER2, you look at the centromeres of the chromosome. Each chromosome is supposed to have 1 centromere, and then 2 copies of the gene. So the ratio needs to be 2 under normal conditions, but if it's amplified, then the ratio is greater than 2, and that's what you call HER2 positive. And then you have hotspot panels where you go for regions of DNA where you most likely will find an alteration and look for substitutions, which can be insertion, deletions, copy number alterations, or rearrangements, and you get your result. However, one should keep in mind that there could be missed areas between these hotspots. So on the top, you see the gene with various exons. Exons are the coding regions of the gene. Whatever is in between exons, non-coding, is called introns. And then with the hotspot approach, hotspots at the bottom at this strand of DNA, you see a bright orange spots that are clinically relevant alterations. You make a test to look for those regions, and you see the hot spots being blue are catching some of these bright orange spots, and sometimes are missing these bright orange spots. But when you do whole exome sequencing, a comprehensive approach, you catch all of these base substitutions, insertion, deletions, copy number alterations, rearrangements, etc. So that's the way to go. And then tumors also release cells and DNA into the bloodstream. So if you don't have tissue, or if, let's say, a patient refuses biopsy, or it's too dangerous to biopsy, the tumor is close to blood vessels, or, for example, you don't want to risk a pneumothorax in case of a lung tumor, you can do a blood test. We call it liquid biopsy, looking for either circulating tumor DNA, which is what most tests look for, but there's also a way for counting circulating tumor cells per deciliter of blood. And it has been tried to even prognosticate tumors, to treat patients and see if those circulating tumor cells go down or not. One such study for breast cancer by Southwest Oncology Group actually failed to popularize the test as clinically relevant. So liquid biopsies utilize circulating tumor DNA and circulating tumor cells for genomic analysis. They can be done on any bodily fluid, not just blood. It can be urine. For example, EGFR is concentrated in urine. A test has been developed to look for EGFR in urine. It can be cerebrospinal fluid of patients with various types of brain cancers or brain metastases or leptomeningeal spread. And I already mentioned that blood is usually the most commonly used fluid to look for circulating tumor DNA. So now let's get to breast cancer. We have divided breast cancer into three categories for decades. Actually, it was more than a century ago that Professor Beatson described hormonal sensitivity of breast cancer, first in oophorectomized cows in 1896. So we have had drugs to block estrogen receptors for more than 4 decades, i.e. tamoxifen. And later on in the mid-90s, we got aromatase inhibitors. Prior to that, oophorectomy in premenopausal women was a known maneuver. And now we have gone in the ER-positive domain, which is 2/3 to 3/4 of the patients, to recognize that 40% of these have PIK3CA mutations. HER2 was the next marker, which Dennis Slayman described in 1987 as a prognostic marker that these cancers tend to be aggressive. And we made a designer drug, trastuzumab, approved in 1998. So even that was 22 years ago. And this is about 15 to 20% of the population. And those patients who don't have any of these receptors, they don't have ER or PR or HER2, are now called triple negative. These patients always existed for centuries, but this term triple negative entered the literature sometime around year 2005 or 6. Now we know that 41% of these patients are PD-L1 positive by an antibody SP142. If you test by a different antibody, 22C3, which is a companion diagnostic for pembrolizumab, it can be as high as 85%. So now we are parsing out subsets of subsets. And as you see here, recently we added multiple other markers. So we live with hormone receptors for more than a century, HER2 receptor practically for less than 1/4 of a century. And within the last decade, we have added BRCA mutations, for which we have PARP inhibitors listed here. We have PIK3CA mutations, for which there's an FDA-approved drug, alpelisib now. Microsatellite instability has been identified as a target for which pembrolizumab is approved in a tissue-agnostic manner, which means that it doesn't apply to any single organ-based cancer, but any cancer found in any organ. PD-L1, for which atezolizumab is approved for triple-negative breast cancer. And now pembrolizumab is about to be approved based on Keynote 355. November 28th is actually the deadline that FDA has. And tumor mutational burden for more than 10 mutations per megabase, pembrolizumab is approved, again, tissue agnostic. NTRK, another tissue agnostic approval. By tissue agnostic, like I said before, I mean, it's not just for breast cancer. It can be breast cancer, lung cancer, colon cancer. If you have these alterations, we have approved drugs now. So for NTRK, we have larotrectinib and entrectinib approved. And HER2 mutations, not to be confused with HER2 overexpression, which would be tested by immunohistochemistry as 1+, 2+, 3+, or amplification, which would be tested by FISH or any ISH. For that, we already have tests. But this is mutation in the DNA. For example, pleomorphic lobular breast carcinoma, which is mostly ER-positive, HER2 negative, up to 20% of those patients can have HER2 mutations, making them candidates for anti-HER2 manipulations. So with small molecule tyrosine kinase inhibitors or even other drugs. So we have neratinib and tucatinib currently that could be used. And then we have emerging targets such as AKT, MEK, FGFR, Fc gamma receptor genotypes. Fc gamma receptor, basically 85% of patients are homozygous or heterozygous, and I won't go into the details. It makes it more attracted to the Fc gamma part of trastuzumab, and because of that affinity, trastuzumab is effective in 85%, less effective in the 15% of patients. And a new drug, margetuximab, is more effective in these patients. That's about to be approved by FDA. So I'll answer the question here, how many patients do we need to test or who needs to be tested in breast cancer? I would say that it's more fruitful to test the triple negative patients in general. And in the ER-positive subset, 40% of patients will have PIK3CA mutation. So after they have failed first-line hormonal therapy, we could test them for candidacy for alpelisib. And if you're not going to give alpelisib, and if you don't have access to targeted therapies, or patient cannot afford targeted therapies, then of course, it's not useful to test them. It's just an academic exercise. These therapies have made their way into the NCCN guidelines, as you see here. So it's very heartening that we have multiple options for patients rather than just hormonal therapy and anti-HER2 therapy that we've lived with. This is just one example, one study looking for genomic alterations in 1,445 relapsed or refractory invasive breast cancers. Each bar is a mutation, and the height of the bar reflects the percent of patients who have that alteration. And when you look at the left-hand side, you see that P53, which is a tumor suppressor gene, and when that's altered, the brake fails on the cell, and there's uncontrolled proliferation. That's the most common, up to 60% of patients. Then you see PIK3CA, MYC, MCL1, CCND1, FGF19. And after the first 9 or 10 bars, you see that the frequency of gene alterations drops below 10%. So it's really smaller and smaller subsets of patients. Breast cancer, which is a very common, and in females, the most common malignancy, as you can see here, is now being parsed into smaller and smaller subsets. Same thing happened with lung cancer, where we have way more drugs. But these common diseases are becoming large collections of rare diseases as our understanding develops. Infectious disease doctors have known this for decades. They call a disease by the microorganism that's causing it. They don't call tuberculosis of the spine and colon and lung by different names. They call it tuberculosis because they know it's being caused by Mycobacterium tuberculosis. Whereas oncology developed decades later, we have been calling cancers by the organ where it's found. Any kind of malignancy in breast is breast cancer. Any kind of malignancy in lung is lung cancer. That's like causing any type of problem, whether it's political unrest or a flood or a hurricane or an earthquake in a city by the name of the city rather than telling us what it is, what's the problem, like calling it Karachi trouble, Lahore trouble, Peshawar trouble, Dubai trouble. So that's what oncology has been. And now we are beginning to understand the basis of it. So in breast cancer, detection of HER2, which I told you has been going on for more than 20 years. Amplification highly correlates with FISH results on the same specimen. Now, comprehensive genomic profiling also detects mutations, which we have not been detecting by IHC or FISH, and we can target these patients, give them treatments that are anti-HER2. And it can also detect other unexpected targets in relapsed refractory metastatic breast cancer that are sensitive to targeted therapies. An example would be PIK3CA and alpelisib. Triple negative breast cancer has a variety of targets, DNA repair defects for which we have PARP inhibitors for BRCA1 or 2, FGFR amplifications, EGFR amplifications, ERB2, which is HER2. This is a mouse equivalent of HER2. MET amplifications, KIT mutations, and mTOR pathway targets. But the field is not as developed for us to have drugs for all these targets for triple negative yet. I'll just leave you with one example. MET pathway is active in triple negative breast cancer. And this led to the hypothesis that activation suppresses inflammatory response to T cells, leading to reduced antigen presentation and PD-L1 expression. Combining MEK inhibitors with anti-PD-L1 inhibitors may improve antigen presentation while blocking PD-L1 mediated expression. So this trial is an example of combining immunotherapy with targeted therapy with the old traditional chemotherapy. And I won't bore you by reading the numbers, but the idea is to explain the concept that if you break the cells with chemotherapy that spills the antigen that's recognized by the immune system that has just been awakened by immunotherapies such as atezolizumab, which is a PD-L1 blocker. We have multiple PD-1 blockers such as pembrolizumab. And then you also block the pathway that's activated. So you use a triple approach to shrink tumors. This is a waterfall plot, as it's called, where the baseline is the measurement of the tumor prior to treatment, and bars that are above the line are tumors that did not respond but actually grew. 20% is the cutoff for calling it progression by RECIST criteria. So you can see some bars going above 20. And then 30% is the cutoff for shrinkage to call it partial response. And green bars are complete responses. So this is a good way of depicting every patient on the slide. Previously, we are used to seeing Kaplan-Meier curves and percentages, but now smaller, smarter trials that we are doing currently allow us to show every patient on the slide and what happens to them. So it's a nice visual concept to see response. So in summary, breast cancer is a highly complex disease. If a patient presents with advanced refractory metastatic disease, broad molecular profiling can help guide therapeutic planning. Again, as I said before, this may not be ready for prime time everywhere, but when you have drugs, patients can afford drugs, then it's very useful technique to find additional options. Patients with triple negative breast cancer have poor prognosis. Chemotherapy used to be the treatment option, and now we have immunotherapy. In fact, we have an antibody drug conjugate, sacituzumab govitecan, that got approved. And patients with rare subtypes of breast cancer have limited treatment options. Patients such as metaplastic carcinoma, etc. Molecular profiling can identify new treatment options for those patients. And liquid biopsy is an option if tissue is not available, particularly in patients with significant tumor burden. So I'll stop here. Thank you very much for your attention.
Thank you, Jahazeb. It was an excellent talk. Really made it easy for all of us to understand this very difficult topic. So we'll ask you a few questions during the session. So
Sure.
now I'll invite Dr. Parvez Rahman. He's a medical oncologist from Pittsburgh. He's clinical assistant professor at University of Pittsburgh, and he graduated from Daw Medical College. So he's been in the US for a long time, trained from Georgetown University. He's got special interest in breast cancer. So he's going to talk to us about updates in triple negative breast cancer. So Dr. Rahman, welcome. You can share screen now.
I am really thankful to the Shaukat Khanum Hospital and the steering committee. I would like to thank Dr. Neelam Siddiqui and Dr. Sumaira Butt, who've been basically kind of spearheading the whole arrangement, and it's not easy. Additionally, it's an honor to be part of the to share the podium with Dr. Jahazeb, who's really one of the thought leaders in breast cancer in US. Next slide, please. I have no financial disclosures, thankfully. Next slide, please. So as you can figure out that Rafa Nadal is my favorite sports person, and there's a reason for that. Rafa is known for his relentless, he's a relentless warrior when he comes in. He just won the French Open the 13th time, so we need his spirit to, he gives me that spirit to overcome triple negative breast cancer, which we must do. Next slide, please. Okay, so we have an outline here. We have a background, then we're going to go into the nitty-gritty of what are the current recommendations, what are the future recommendations. Dr. Jahazeb has made my job a lot easier because he covered a lot of the molecular targets and the treatments for triple negative breast cancer. But this first slide is, we cannot kind of make this minimal that it only, TNBC only makes up 12 to 15% of all breast cancers. If we are to presume that there will be close to 200 to 250,000 breast cancers in the US and close to 1.6 million breast cancers in the world, that makes up for a staggering number. I think the other take-home message from this slide is that the patients are young patients. They are premenopausal patients. They're young mothers. They're young wives. And so we have to treat them comprehensively the first time when they walk in through the door, because once they recur, the time to recurrence is only between 1 and 3 years as compared to, say, hormone receptor positive breast cancer, where it can be 5 to 10 to up to 25 years. And once it relapses, the overall survival of these patients is somewhere between 12 to 18 months only. So we have to do a lot more. It's an unacceptable overall survival. Next, please. Doctor, there's a slide before this one. Okay, so I think there's probably a slide that's going to come after this. So neoadjuvant chemotherapy is really the benchmark for these patients when they come in for a triple negative breast cancer. And the reason is that these patients are going to die of systemic disease recurrence. So there's an urgency to start systemic treatment rather than treat them later after surgery. So neoadjuvant chemotherapy has become a benchmark for these patients because we want to get them to a pathological complete response. We believe that pathological complete response is a surrogate for long-term benefit and survival. Dr. Jahazeb, no, I need to go back to the previous one. Dr. Jahazeb has actually covered most of the targets that I have mentioned here, but the most important take-home message. Could I go to the slide before, please? So the most important thing in this mutational landscape is that it's transforming. This is just a few that I have mentioned. Dr. Jahazeb's presentation had a lot more molecular targets, but the most important thing is that all the targets that I have stated here now have a drug against it. If they're not in clinical practice, they're actually going through clinical trial. And I think the take-home message is that future genomic interplay will dissect out pathology based upon actionable mutations. So if you look at this slide, it reminds me of bronchogenic adenocarcinoma slide. It is not one size fits all. It is going to be based upon molecular targeting. So really, TNBC is a misnomer because yes, it is a triple negative breast cancer for the traditional targets, but now we have the target. So it's not a negative target anymore. It's all positive. Next slide, please. I think I've covered this, that neoadjuvant chemotherapy is the benchmark. If you remember Sir Richard Peto's presentation at the San Antonio Breast Cancer Conference, he mentioned the dose-dense AC followed by dose-dense Taxol, which is still being used in many academic centers. I know that there's been modification to this. People give weekly paclitaxel and nab-paclitaxel, but the original Larry Norton recipe, Dr. Peter was able to show that there's a 4.7% gain in 10-year survival. So I think chemotherapy is here to stay, and we will talk a little bit about as to why that is so. Next slide, please. Okay, so if you look at this slide, the evolution of breast cancer has, I started in 1987 when I was in New Zealand, and we used to look at the morphological diagnosis. We used to go to the pathologist, look under the microscope and say, okay, this is breast cancer. Then in the late 1980s, early 1990s, we had the estrogen receptor positivity that made us dissect out that, okay, you cannot treat all patients with breast cancer with an anti-estrogen modality, but only the ones who are estrogen receptor positive. And then we move on to the third portion of this with Dr. Chuck Peru bringing up the human genome, unraveling the human genome. And then we started to really profile the cancers according to gene expression, moving on to multi-omics, where we are now looking at molecular targets and picking up drugs according to their molecular portraits. And I think the screen on the right side is kind of, I can't see it, but now we have gone into immune profiling, and finally the immune therapy has reached the door of breast cancer treatment. Next slide, please. I'm sorry, I'm going to go very fast because there's so much to cover. I came to my office at 100 miles an hour because my computer crashed at home, and I think this presentation is also going to be 100 miles an hour. It was the Vanderbilt group that saw TNBC initially as not one disease, but as multiple diseases, and they subclassified it into 4 different types. The basal-like immune activated, as you can see, the immune activated means that these are hot tumors. If you look at them under the microscope, you see a lot of tumor infiltrating lymphocytes, as compared to the one below that, basal-like immune suppressed, where you don't see a lot of T cells. So you can now imagine that the basal-like immune activated will respond much better to immunotherapy as compared to basal-like immunosuppressed. Now it is a research question. How do you convert basal-like immunosuppressed to basal-like immunoactivated? And that's a whole different lecture. And then the mesenchymal and the luminal androgen receptors, where the breast cancer overexpress androgen receptors. Next slide, please. The presentation for immunotherapy cannot be complete without this cartwheel. If you look at number 1, the first, this is a cartwheel showing how the immunotherapy works, how somebody or a group of researchers sat down and said, let's draw the immunotherapy cycle in a cancer. And we're talking about breast cancer. So the first is, how do you release cancer antigen? You release cancer antigen by killing the cancer cells. Once the cancer cells are killed, it liberates tumor antigens, which go to the second part of the cycle, which is the tumors are taken up by the antigen presenting cell, goes for priming and activation into the lymphatic system, rushes back into the bloodstream, infiltrates the tumor, recognizes the tumor by way of the antigen that they already knew of, and then here there's a reaction that kills cancer cells. So you can just imagine that it is a close interplay between the chemotherapy, or for that matter, radiation therapy, or for that matter, PARP inhibitor. And the final step is actually the killing of the cancer cells by your own T cells. Next slide, please. So this is a magnified view of what happens when the T cells actually interact with the tumor cells. The tumor cell is in the light brown, the T cells are blue. You can just see that the antigen is being presented, the T cell is being activated. So the T cell brings out the PD-1 ligand to actually recognize the tumor cells, but the tumor cells are smarter than us. And what it does is it brings out a PD-L1 ligand, and it is called the immune handshake, where the PD-L1 handshakes with PD-1 and says, I'm your friend, don't kill me. And the T cells go into a state of slumber. Now you can see that the orange handshake has to be broken, and that's where atezolizumab, which is a PD-L1 blocker, and pembrolizumab, which is a PD-1 blocker, they come and break that handshake, and suddenly the T cells recognize tumor cells and overcome them. This was the basis for winning the Nobel Prize by, not the Peace Prize, but the Nobel Prize for Medicine by a Japanese scientist 2 years ago. Next slide, please. Thank you. So this led to the phase 1 trial looking at whether pembrolizumab in advanced triple-negative breast cancer had any role. Yeah, I do have a pointer. That's great. So what was seen was that you will see a number of patients responding, but the most important thing was, and we see that with lung cancer and bladder cancer, that when you see these responses, these are durable responses. Again, the numbers are hiding behind the screen, but the responses are about 20%. But the most important thing is that a number of them will show durable responses. Next slide, please. Okay, so the slides are a little bit muddled up, but anyway, let's cover the PARP inhibitors as well. This is a very simplistic slide from Dr. Jeffrey Shapiro, who's really a thought leader in kind of the genetic basis of breast cancer. What this shows is, you know, before we look at PARP inhibitors, we need to know how it works. So PARP is a very important enzyme that actually repairs single DNA breaks. If the PARP wasn't there for any reason, say you gave a PARP inhibitor to these patients, it leads to double strand break. However, there is the homologous recombinant pathway. One of the major genes there is BRCA gene, and it actually repairs the double strand break. However, if you have a deficient homologous recombinant pathway, then what happens is that these dysfunctional BRCA genes actually go through an alternative pathway and tell the PARP to keep propelling their cancer growth. So some of the smart guys sat down and said, what if we stopped PARP? And now that process is called synthetic lethality. So they brought it to the clinics, and they were able to show that if there is synthetic lethality where both PARP is inhibited and BRCA is deficient, it leads to killing. And as you can see, I don't know whether Dr. Jahanzeb showed this in his slides, but as you can see, if you give these patients PARP inhibitor, it leads to tumor shrinkage. Next slide, please. So now we're going to drive right into the preoperative immunotherapy treatment. This was the Keynote 522 trial. And what we saw was that if you combine, so I'm not going to go into the nitty-gritty of trial because there's so much to cover. But what I'm going to show is that if we believe that pathological complete response is a surrogate for survival, then we have to show that whatever we are doing, in this case, preoperative pembrolizumab, leads to a higher pathological complete response. And hopefully, it has not been proven as yet, and hopefully lead to more patients surviving. So this was clearly a trial using looking at carboplatin paclitaxel, fairly standard, followed by doxorubicin cyclophosphamide, or epi for that matter, combined with pembrolizumab, compared to placebo in a 2:1 trial, large number of patients. Next slide, please. And what we see is clearly that patients who received pembro and chemo had a 13.6% improvement in pathological complete response in terms of all comers. But if you look at PDL, and then if you tease out PDL1 positive and PDL negative, interestingly, you get a 14 to, I can't see the number behind my screen. I think it says 18%. So clearly you can see this is what we were looking for. The primary endpoint was pathological complete response. We see a 13.6% improvement. Next slide, please. And so CPS score is a PD-L1 expression biomarker that was used in patients who received pembrolizumab. And as you can see, that all comers for CPS score less than 1, you have an 18.3%. And as you go up on the CPS level, CPS is a composite score of lymphocytes, some other neighborhood immune cells, and there is a formula. It is divided by the viable tumor cells. And we know that as the CPS score increases, so does the pathological complete response. Next slide, please. This was another trial. It was IMpassion031. So the first time we used pembrolizumab, which was a PD-1 inhibitor. Atezolizumab is a PD-L1. So fairly similar trial where patients received preoperative atezolizumab. These are smaller numbers, 333. This is a randomized trial for triple negative breast cancer. Now, as you can see, non-metastatic, but locally advanced. Atezo combined with nab-paclitaxel, fairly standard, followed by atezo combined with AC, and then the other arm of the trial into 1:1 randomization containing placebo. They underwent surgery. Again, I can't see the right side of the screen, but it looks like patients who received atezo post-op, but these patients continued the placebo. Next slide, please. What do we see in pathological complete response? Next slide, please. Okay, so here we are. Also in IMpassion031, you see a numerical increase of 16.5% in the atezo-treated arm as compared to the placebo-treated arm. You would ask me whether this is statistically significant. The p-value is 0.0044, so the statistical endpoint has been met. Next slide, please. Now, if you look at PD-L1, now this is intriguing. So you have a 19.5% increase in patients who are PD-L1 positive, but you also saw an increase of 13.3% in PD-L1 negative patients receiving atezolizumab. So there may be other biomarkers, there may be other interplay, genomic interplay, and this is going to be hashed out. Now, if you look at the, it is too early to look at survival data, but if you look at them, it's kind of showing about a 24 to 36% improvement in different survival parameters. Next paragraph, which of the chemotherapy drugs is better? This is from the TONIC trial. And again, I cannot see the right side of the slide, but it looks like anthracyclines and cisplatin are the favored drugs. Next slide, please. Okay, so the current standard of care, we know if you have a patient who has undergone a neoadjuvant chemotherapy and they have surgery and they have residual disease burden, then if we remember the CREATE-X trial, it showed a survival advantage. So capecitabine is the only modality available in the post-operative setting. However, we all know as oncologists that the doses that we need to administer to patients after they've gone through neoadjuvant chemotherapy, after they've gone through surgery, is rather difficult, but I have done it in patients who have significant residual burden of disease, but it's not easy to give. Next slide, please. So do all patients need pembrolizumab in the neoadjuvant setting? Clearly, this slide in one statement demonstrates that as you go up on your staging, if you're 2A compared to 3B, there's an incremental improvement in response and pathological complete response. And it seems to be the highest in patients with node-positive patients. So if you asked me, if you stopped me right now and said, who should get a neoadjuvant, whatever immunotherapy you want to use, I would say a young patient who shows strong biomarker for PD-L1 who have node-positive disease. That would be the patient that should be targeted. Next slide, please. And if you look at, obviously, lymph node negative disease, just the point I made right now, that the incremental response seems to be clinically more beneficial for patients with node positive disease than node negative disease. Next slide, please. Okay, so it was actually there was a I-SPY2 trial. It's a platform trial. The I-SPY2 platform had to prove that if the probability of the drug working in more than 99% of patients, the probability had to be more than 99%. So pembrolizumab was placed on a I-SPY2 platform, and it was able to prove that the pathological complete response went from 20 to 60%. It was actually the I-SPY2 platform that led to Impassion 130. This was clearly metastatic and locally advanced inoperable breast cancer, good ECOG performance status, eligible for taxane chemotherapy. And this trial used atezolizumab combined with nab-paclitaxel. And in one, I'm just going to show the overall survival. If you remember from my first slide, the median overall survival for patients with recurrent disease is 14.5 months, somewhere between 12 and 18 months. And you can see that in PD-L1 positive patient, mind you, PD-L negative patients did not benefit, but PD-L positive patients had a median overall survival of 25.4 months. And this is clinically very relevant with a hazard ratio of 0.69. Likewise, Keynote 355 used pembrolizumab with chemotherapy. I cannot see it, but I think it was the endpoint was met. Next paragraph, next slide, please. And you can, yeah, so if you see, the most of the benefit was seen in patients who had a CPS score of more than 10, whereas in all comers and those who had CPS score low, there was really no difference in survival. Next slide, please. Impassion 131 design, I'm just going to show you one more slide. It was really atezolizumab combined with paclitaxel in a 2:1 randomization, and it did not show a survival benefit. So this is, again, open for discussion. This is the most important thing. No new safety signals with the use of immunotherapy. If you combine pembrolizumab with atezolizumab, there were more toxicity seen with pembro than atezo, but the toxicities were manageable. It was mostly thyroid disorder, mostly skin rash, and a smatter of hepatitis and others, but there was no interactive toxicity. That means the chemotherapy and the immunotherapy did not lead to an interactive enhancement of toxicity. So no new safety signals. It is safe to give, and the adverse reactions are manageable. Next slide, please. Okay, so now we jump on to Dr. Shapiro's his dogma, whether if you give a PARP inhibitor to patients with germline BRCA mutation, can you get a response? So now you're going from the bench research to clinic. So these were two randomized clinical trials, first using olaparib and Embraca. This was a phase 3 trial randomized between olaparib and the physician choice of chemotherapy. As we can see, we were very, the scientists and the clinicians were very happy that it showed a progression-free survival advantage. Next slide, please. However, we just saw the overall survival analysis results, and the lines are not diverging, so there was no. I think we can just mention that besides germline mutation, there are other mutations like the PAL-B2 mutation, which is part of the HRD pathway, and they also seem to benefit from PARP inhibition. So the story moves on. Now the PARP inhibitor, can you go back one slide? Okay, I think we're good. Next slide, please. Okay, so this is now, as Dr. Jahazieh mentioned, that PARP is now being, now we are looking at these combination trials where you're going to see immunotherapy and chemotherapy and these PARP inhibitors being used together, because as I said, you have to come up with the best molecularly targeted treatment and do the best for the patient the first time, because we also know, you know, we were always taught that chemotherapy followed the law of diminishing return. The first time the chemotherapy worked best, the second time less best, and the responses were less. The same goes for immunotherapy. If you use immunotherapy upfront, you get a response of 20 to 25%. When you use it second line, you get a response of 5 to 8% only. Same goes for PARP. If you use it before chemotherapy, the lines seem to be divergent. But if you use after chemotherapy, it doesn't seem to have the same benefit. So I think all of these targeted drugs needs to be used first as the best possible treatment for our patients, depending on what their molecular signatures are. One thing did come up, that if you have somebody who is platinum sensitive, but they've reached the maximum of their chemotherapy cycle, you can continue the PARP. And as you can see, the line diverges. So it is a parallel to ovarian cancer, where we feel that PARP inhibition in a maintenance setting is where this might help. Next paragraph. Okay, so we are coming to the end of my discussion. We know that PI3 kinase and AKT alterations are seen in a whole host of the subtypes of triple negative breast cancer, confirming that it's a heterogeneous disease. You have to look for targets. The example is that if we feel that PI3 kinase makes for 5% of all, I'm just giving you a number, of TNBC, and you treat all of them, then guess what? 95% won't respond. Only 5% will respond. So you have to tease out these genetic expressions or alterations and then treat them with the drug that you have. Next slide, please. So as we can see, these were two trials, the Lotus trial and the PAC trial. No, please go back. Please go back. All comers did not respond, but if you teased out if you teased out patients who had the AKT pathway alteration, then you saw responses. Next one, please. Same goes for androgen receptor. We have used androgen receptor deactivators for a long time for our prostate cancer patients with success, but the androgen receptor pathway seems to be more complicated in TNBC. So there will be more, you will hear about it in the years to come. Next slide, please. And you can see that if you use bicalutamide, or for that matter, the newer ones, enzalutamide, your clinical benefit ratio is in the order of 19 to 20%. No, you have to go back, please. And so it means that androgen receptor blocking agent may not be the only drug you want to use. You might want to use it in combination. I'm going to finish up. This is my favorite slide. This is the antibody drug conjugate. I love these drugs. I think this is going to come in the first line setting. I think if somebody called me and from Pakistan and said, what is one drug that we should have for triple negative breast cancer, it would be this drug. What they have done is they have combined chemotherapy with an antibody, a humanized antibody that actually recognizes the TROP2 antigen on the surface of the cell. I've heard different speakers saying maybe TROP2 does not have any prognostic influence. Other speakers have said that yes, TROP2 overactivation may be a bad prognostic side. Next slide, please. So what happens is you have a humanized antibody combined with a drug called SN38. SN38 is a cousin drug of irinotecan, but has not made it to breast cancer treatment because of its toxicity profile. But guess what? If you can combine it with an antibody and deliver it to the inside of the cell, then you may not see the systemic toxicity of this drug. And that's where this comes from. You have the linker that links SN38 to the antibody. The antibody goes into the circulation, fixes to TROP2, internalizes into the cell, and then breaks down, not only killing the cell, but then it oozes out of the cell membrane and has this what's called a neighborhood effect, or an effect that it not only will kill TNBC, but it may kill a whole host of cancer cells around it. And next slide, please. So this is the makeup. It's TROP2 is expressed on all subtypes of breast cancer linked to poor prognosis. This was initially presented by Dr. Aditya Bardia from Dana-Farber, showed that there was definitely an improvement in progression-free survival, hazard ratio 0.41. This was just recently presented at ESMO. The overall survival is maintained. Next, please. The toxicities were manageable. All subgroups actually had benefit. And the last slide is acknowledgement. I really want to thank ASCO International, especially Sarah Backman. I want to thank all the ASCO speakers. I want to really thank Sarah Tolani, who helped me organize my talk, and then all the other thought leaders in TNBC in the United States. Thank you so very much. We'll open it to questions.
Okay, thank you, Dr. Pervez. So I'll let Dr. Azmeena moderate the challenge the expert session. Dr. Azmeena is a consultant medical oncologist from Aga Khan, and we also have some other very eminent oncologists here. Professor Zeba Aziz, she is the pioneer of medical oncology in Pakistan. She doesn't need any introduction, but still I want to see you, Zeba. And we will have Dr. Shahina Dawood as well. Shahina, please unmute. Yes, we can see. So Azmeena, over to you. You've heard all the talks, so we can, start from.
Hello.
Or maybe, okay, you can start. Just one question to the surgeon, because he came promptly, he's been waiting. Professor Grobmeier, I think your talk was excellent, and it showed us how much surgery has evolved. Do you think there will be a time when some patients with breast cancer they will not need surgery? But if you can start talking, I'll call
Yes,
somebody.
I certainly think there will become a time when fortunately surgery won't be required. They're actually in South Korea and now at MD Anderson, there are prospective trials where patients with HER2 positive or triple negative breast cancer actually have extensive sampling of the tumor bed. And if they have no evidence of residual disease, then they're treated with radiation therapy and then just followed. And I think as the drugs get better, and there's a lot of exciting things that we heard about during this session in terms of the drugs, that hopefully we will evolve one day to where this will be the mainstay. But it's obviously a lot of work to get there. So stay tuned.
If I may ask a question, Neelam, to Stephen, is that okay?
Yes, sure. Yeah.
Stephen, excellent lecture. This is Shahina here from Dubai. Quick question about inflammatory breast cancer. Usually these patients constitute about 1% to 2% of all our breast cancers, and they're very, very aggressive. The mode of treatment is Neo-Adjuvant followed by a mastectomy. But is there a role? I know all surgeons will go in for axillary lymph node dissection, but with newer targeted agents, these patients are doing very, very well. They're getting their PCRs. Is there a role at all for sentinel lymph node or axillary lymph node sampling rather than subjecting them to a full axillary lymph node dissection and the morbidity associated with lymphedema after that?
So I see all the questions have been very effectively answered by Professor Janzeb. I have a few questions though. So from Dr. Parvez Rahman, so much has been happening in triple negative disease with immunotherapy and PARP inhibitors and the antibody drug conjugates. But within the genomics of triple negative disease, we see their androgen receptor expression also. And so what is the significance of these androgen receptors and what is the possibility of drugging this receptor in patients?
Right. So I think that answer is coming. I think we are not we shouldn't be complacent with a clinical benefit ratio in the order of 90 to 20%. I think where this is going is that AR receptor blockers will need to be combined with other modalities of treatment. And I know, and I think Dr. Janzeb showed some slides where AR will be combined with pembrolizumab. Maybe some other. I think what you have to do is you have to look for other mutations and then combine the drugs and go for the mutation. I'm not sure that giving the patient enzalutamide is enough. In fact, I've had patients in my practice and they have not responded really. So I think the jury is out. I think over the next few years, there'll be more trials showing that combination treatment or combination molecular targeting is probably going to be the way to go.
Okay, so then if there are no questions, then I can keep on asking my questions, my set of questions.
Can I ask a question, please?
Sure. Yes.
I'd like to ask Janzeb and Dr. Parvez that if you have a strong androgen receptor positivity and you've given neoadjuvant chemotherapy, you've done surgery, is there a role of androgen receptor as adjuvant, just like we use for tamoxifen or AIs for ER positive? So if we have an androgen receptor positivity, which is strong, are there any trials or any work done on adjuvant AR receptor positivity?
Not to my knowledge, the adjuvant yet.
I think these are answers that are going to be matured in the next several years. I think the researchers and the clinicians and people who are in the large academic centers are seriously looking into it, but I don't think it's prime time as yet. And I generally don't do next generation sequencing on all my triple negative breast cancer. If a woman comes in, she is very young, she has metastatic disease, I'm more interested to know whether she has a BRCA germline mutation that I can target, whether there is PD-L1 positivity where I can use nab-paclitaxel atezolizumab. I think NTRK mutation or the TRK mutation is very, very unusual. I mean, I have not seen a TRK fusion as yet in my lung cancer and colon cancer patients. I think it is just like winning a Pennsylvania lottery. I don't do NGS unless if I run out of options and now I'm stuck and I want to do something more for my patients. But I think the ADCs are really here to stay. I think the toxicity is manageable. I think you will see more ADCs coming through. I think these patients will have more options available. I think ADC will become first line. I think ADC will be combined with immune checkpoint inhibitors. I think other targeted therapies are going to come. I think the landscape is going to completely transform, but I'm not sure whether we would give AR, post-op adjuvant or in the neoadjuvant setting. I don't think we have answers.
So possibly the same question, Janzeb, like in your clinical practice, who are the patients that you get, breast cancer patients that you're doing NGS on? Because we are now getting a lot of pressure from, like different sides that we need to be doing NGS and we need to be doing circulating tumor cells. And so in your clinical practice, how often do you use it?
Circulating tumor cells were looked at in a randomized trial by Southwest Oncology Group, I think Dr. Smerge published that. So the answer to that is I don't do circulating tumor cells. As for NGS, all breast cancer patients go through multiple lines of therapy. So it's usually in the subsequent line therapy where there are applications of NGS. I don't do it up front in everybody. We do the traditional ER/PR, HER2. For triple negative, we check PD-L1, of course, because you cannot give the drugs without knowing the PD-L1 status. But a typical example would be somebody who has failed first-line hormonal therapy. You would want to know their ESR1 status to see if they have developed resistance to aromatase inhibitors. So you would steer them towards fulvestrant type therapies and not try aromatase inhibitor or tamoxifen. And then if somebody is pleomorphic lobular, as I said in my talk, up to 20% of those patients have HER2 mutations. So they are otherwise traditionally HER2 negative, but if they have HER2 mutation, that opens up a whole host of other options for treatment in those patients. And then PIK3CA in second line ER positive setting in metastatic disease, you would want to know the PIK3CA status before you can prescribe alpelisib. So those are the examples where I would use NGS. It's definitely not ready for wholesale prime time use in everybody upfront. It's not like lung cancer. In lung cancer, not knowing the mutation status of an adenocarcinoma is like treating a breast patient without knowing ER, PR, HER2. So lung is different.
Yeah, but like the early stage, the studies, Neo-Adjuvant studies of immunotherapy in triple negative breast cancer. To me, what I understand is that PD-L1 may not be that important a marker because China, you can comment on that. So in metastatic, yes, but in early stage, like PD-L1 positivity did not make a lot of difference. Am I right?
You're completely right in the early stage setting, and we have two trials now. One is the Impassion trial, and the other is the Keynote 522. Both suggested that PD-L1 is not necessary. You do not have to test for that for patient to benefit. Although there was a trend towards an increased PCR rate, the more enriched a patient had in terms of PD-L1 expression. But in the metastatic setting, the target is completely different, and you do need the PD-L1 because if you're PD-L1 negative, there is no benefit for immunotherapy in the metastatic setting. You're just adding toxicity without benefit. But I'd like to circle back to the question that you asked about molecular profiling. And I'm going to be the odd one out because I'm usually the odd one out. And, like we have three subgroups of breast cancer patients. We as clinicians, we're very simplistic. So we have our patients with HER2 positive disease. I don't think NGS really works in those patients. We have a good target, multiple lines of therapy available. In patients with triple negative breast cancer, they do very, very badly. Their prognostic outcome is very poor. And when I get a patient with metastatic triple negative breast cancer, I want to know the biological makeup of that patient. And if feasible, because finances does make an issue, if feasible, I will profile that patient. And recently I've started profiling most of my hormone receptor positive patients upfront, again, only if feasible. And I've found really interesting, information. I have patients, I have a patient right now with ER/PR positive, PIK3CA mutation positive at an NTRK fusion. And the question is, how am I going to sequence everything? I have a patient right now with a BRCA-somatic mutation, not germline, has a HER2 mutation at baseline and an ER/PR positive disease. Again, how do you sequence? But at least it gives you that information that you can discuss in your molecular tumor board, and you're giving options to your patients. You're able to actually have that full information. Yes, targets change over time, for sure. You'll need to profile again. But I think if cost was not an issue, I would do it. If cost is an issue, I agree completely. You don't do it first line.
I think the problem in US is that you have to fight the insurance companies to get medications, number one. Number two, I think whenever you pick a medicine, you have to look at randomized clinical trials because that's the position that you will end up with. You will have these multiple molecular targets and you would not know. And I think in your PIK3AC mutation and the NTRK mutation, you'll probably follow the clinical trial that showed PIK3A is going to give you a response. Going back to what Dr. Jahazeh was saying, another thing that I did not mention because of paucity of time is triple negative breast cancers who demonstrate HER2 1 and 2, which are deemed as negative. And there was I think it was a phase 1 trial using famtrastuzumab deruxtecan, where they showed a 30% response. So that's another antibody drug conjugate. I recently had a patient with breast cancer. She has a history of rheumatoid arthritis and Felty syndrome. I could not give her any chemotherapy over the last 3 to 4 years. And I used up all the agents, including Kadcyla. And here she comes in a wheelchair with a 5-centimeter sternal mass. And I knew, and at that time, a trastuzumab deruxtecan got approved. I gave it to her. I'm telling you, I'm not making it up. 2 cycles later, she walks into my office, not even holding a cane, the 5-centimeter ulcerated lesion on the sternum gone. After 4 cycles, she's never had a negative PET scan. After 4 cycles, I gave her a negative PET scan. She feels great. I think moving forward in many of these cancers, I think ADC will replace the traditional chemotherapy drugs. And I think the diarrhea and the neutropenia, we have dealt with it. I've dealt with neratinib-related diarrhea. So the ADC-related diarrhea is not going to be a major problem as long as you educate the patient. So my last 3 slides were the most exciting because I'm really excited about ADC combining with immunotherapy and then bringing in another molecularly targeted like a MEK inhibitor or the ones that Dr. Jahazeh alluded to. I think that's where this is going. But it'll take several years. And until then, we just have to pick up, as Dr. Shaina Dawood said, molecular tumor boards, get your senior partners to sit there and tell us how to tease it out. But I think it is very exciting. I think TNBC has become a misnomer. I don't think it's a negative breast cancer. I think it should be called a triple positive or multi-positive breast cancer.
I completely agree. I wonder if I could ask one question because I see someone's posted a question here on the chat box. Sure. And I think Stephen addressed that issue during his lecture. And I've come across this a number of cases in the last couple of months. So Stephen, you remember Seema Khan's data that she presented at ASCO this year looking at surgery of the primary in patients with stage 4 de novo disease. So when you have a patient, ER/PR positive, I'm steering away from triple negative, making it simpler. ER/PR positive with oligometastatic disease and the MDT decides to start a CDK4/6 inhibitor with endocrine therapy and the patient 3 months later is in CR. 1, would you do surgery of the primary? And 2, if you were going to do it, when would you do it?
In general, I think the trend is we don't do surgery on the primary based on 2 randomized trials. So, I've had patients who have metastatic disease. They have a great response systemically, but they have residual disease in the breast and they have a high performance status and they're young, particularly young patients. Those are ones we will, offer surgery to. But for most patients, if there's no evidence of disease in the breast, we don't rush to surgery.
Even if it's just one spot in the spine, because that's the true oligometastatic disease.
I think the thinking on that has changed as well. I mean, you bring up a good point. So yes, fit patients with oligometastatic disease that we're going to, offer radiation therapy to the metastatic site. Yeah, I think that's reasonable, option, also for those patients. You have to heavily counsel these patients though about what your objectives are and what you know and what you don't know and what the expectations are, and is it really benefiting them? We don't know, but
I think this is a question we ask very frequently, and because we've done it in the past and some of the patients have done really well. So if it's 1 or 2 bone metastasis, they may
in those patients, I think the trend is to do that with radiation to the oligometastatic sites. So yeah, I think it's reasonable.
So, thank you. So I have a question.
Can I ask the medical?
We have some more questions coming in, please. Like these are people, like all the audiences. So this is for Dr. Jahanzeb and Shahina, that if you have a patient with metastatic triple negative breast cancer with germline BRCA positive, PDL1 is more than 1%, how would you sequence? This is metastatic triple negative breast cancer.
Yeah, so in general, I would say,
BRCA positive and PDL1 more than 1%.
yes. So since I do both lung and breast, in general, in lung, my approach is to use targeted therapy first because the response rates are higher, duration of response can be very long. In breast cancer, these BRCA positive patients benefit from PARP inhibitors. It's an additional option, but they're not super impressive drugs. I mean, PFS of 7 months is not something to get super excited about, but it's an option. So the reason I would favor immunotherapy first is that a subset of immunotherapy treated patients achieve long-term survival. They're 15, 20% of patients, but you actually end up having them live years, and PARP inhibitors don't do that. So that's why I would tend to favor immunotherapy first, but I would be curious to know what China does.
Chahina and Dr. Zeba and Azmina also, all of you, I'm going to ask the same question. Yes. What will you do?
I don't think we have a simple answer to this. I think it needs, Dr. Janazeb is completely correct in that you do have a survival advantage with using immunotherapy upfront in these patients. Although it was not statistically significant, there was a clause in that statistical design of the Impassion trial. But having said that, when you look at the Olympia-D trial, amongst patients who did not receive chemotherapy, you did see a survival advantage that was very, very similar to what you saw in the Impassion 130 trial. So for me, if I have, I mean, I think you could do it either way. If you have a patient who is not in visceral crisis, very minimal disease, I don't mind using a PARP inhibitor in those patients, especially if the patient doesn't want to lose their hair, they don't want to be subjected to chemotherapy. But you always have that conversation with your patient that first line survival advantage as of now is with immunotherapy, although I think it's still an option.
I think the
So,
other
Dr.
point.
Zeba, are you using PARP inhibitors because they're really expensive? So
Yeah, we are using it more in ovarian cancer. Yes.
Yes. Okay.
But we get the HRD done, and then we are using it in some of our patients. In fact, today was for another patient which we started on. But the thing is that I would like to know the role of carboplatin in here, because majority of our patients in Pakistan are not going to be able to afford continuous immunotherapy or PARP inhibitors. Even in neoadjuvant setting, despite the data of JEPA-6 and the CLGB, and it's very controversial, how in triple negative are you, what is the role of carboplatins? Because I think that was not discussed in detail, and it is very relevant to our part of the world.
So maybe we can start with Azmina. Azmina can give her view what she's doing, because I use platinum a lot. I don't have.
I do too, and that's why I'm asking you.
So yes, we can hear from Azmina and then.
Yeah, so it all depends on which stage of disease the patient has presented to you. If they've already completed the adjuvant treatment and they've had the anthracyclines and taxanes, and they are, let's say if they are BRCA positive, you know about their status, germline status, but you're unable to give them PARP inhibitors, then the choice of treatment would be carbo with gemcitabine. Although the Brocade trial very well has also discussed that you can have veliparib added to your gemcitabine and carboplatin, and we'll have to see the results of that. So yes, but then it's, you know that this is not going to be a durable strategy, and at some point you will have to introduce or maintain them with something. So I think platinums are indispensable as far as the West or the East is concerned. We all use them. And the other agent, the chemotherapy agent that we have not talked about, and we've talked about targeted treatments in triple negative, is eribulin. And I've had patients who had been 5 years, 6 years disease-free in metastatic disease after Ribulin, as long as they can put up with the neuropathy and they do not have residual neuropathy from the preceding taxanes. So that's my view. The one question that I had was about de-escalation therapy in patients. If we are giving them a keynote 522 like protocol, and they have the taxane and carbo and immunotherapy, pembrolizumab, and they're done with their 12 cycles, and you re-image them, and there is pathological, well, there is complete resolution on imaging modality. Can you spare these patients the effects of anthracyclines and move them to surgery and then continue on with the pembrolizumab? Because here we are talking about escalation of therapy. And at what point in time and what surrogate do we use to de-escalate treatment? So if Dr.
China,
Rahman wants to answer that, or...
So was this, just remind me, was this the neoadjuvant trial or the?
That's right, that's right.
The
Thank you.
neoadjuvant trial. Yeah, so, you know, the trials that will be done in the future, I think they are talking about de-escalation. If you remember the Neo-Trip trial, I mean, they threw the kitchen sink at the patient. There's a lot of chemotherapy given, 8 cycles pre-op, and so I'm not sure. I know that as I presented in my talk that anthracyclines do have a very favorable interaction with immune checkpoint inhibitors. So do platinum, more so than Cytoxan and other medications. I think it's interesting, but again, as far as my practice goes, I stick to clinical trials, I stick to the data, and then I follow those. I just want to make one point that Dr. Shaina Dawood was making about a patient having 2 separate biomarkers and then to decide whether it's going to be a PARP or a PD-L1. I think that's the patient you pick up the phone and call University of Pittsburgh and ask your medical oncology colleagues if they have a clinical trial going on that's combining PARP with immune checkpoint inhibitors, because we need to put these patients into clinical trials, and that's how we're going to get an answer. So at least in my practice, I'm fortunate that I'm connected to the university. I can pick up the phone and put them on clinical. We need these answers, and I don't think I can answer it sitting in my office for a patient who walks in. It'll be very difficult to tease out.
So, China, you wanted to say something?
No, I completely agree with whatever has been said. I think, you know, Dr. Azmina has very correctly pointed out that eribulin is a very important drug in patients with metastatic triple neg. I have patients 3-4 years on eribulin and doing actually very, very well. You just have to dose de-escalate. I think in terms of the neoadjuvant approach that you're talking about, Azmina, the ABC trials have clearly pointed out that we cannot remove anthracyclines from triple negative as of now. It forms an important component. Even if patients have a pathological complete response, these patients do benefit from anthracyclines. So I think de-escalation will not be in terms of removing anthracyclines until we have more data. But I think where we're headed in terms of de-escalation is what to do after you attain a pathological response. And my question that I think, you know, we need to answer in the immunotherapy realm is, after the keynote 522, when you have that pathological complete response, do you need to continue immunotherapy for a year? Because we do not know what the long-term effects of pembrolizumab will be in a young woman long-term. They cause hypothyroidism, they affect the adrenal glands, you get that pneumonitis, the hepatitis, and there can be long-lasting effects on these women. And I think that's where we need to focus our efforts on in terms of de-escalation. We need to prove that in clinical trials.
And plus, you know, I'll give you another example of a patient with metastatic melanoma that I gave just single agent nivolumab, because I didn't think he was an older patient. I only gave it to him for 6 months, and he had liver full of metastatic disease, completely gone. He's a year and a half out without Pembro. Pembro was stopped at 6 months. He's still in remission. So these memory cells and the T cells can remain activated for a very long time. Whether Pembro should be given for a full year after a pathological complete response, I don't know. I take Dr. Shaina Dawood's point of advice that we don't know. What is the effect on fertility? Does a pathological complete response caused by pembrolizumab is as good or as durable as AC followed by T dose dense? I think those answers are all awaited at this point.
Okay, there's one last question that we need to answer. This is from Mohammad Rashid Hanifa. He says, is there any role of checking PI3 mutation at baseline in hormone-positive disease?
Yes.
Yes, yes.
To
And he has approved that.
You're going to sequence your patients, and 40% of patients will be positive for PIK3CA mutation at baseline. Very few will acquire a mutation afterwards, but I will still test them if they're negative at baseline, because you don't want to miss that one PIK3CA mutation positive disease that's acquired, where you could potentially use alpelisib in those patients. But like I said, 40% will be there up front. So test it, keep it ready. When your patient progresses on a CDK4/6 inhibitor, at least you have that information at hand so that you can be prepared for what you're going to give afterwards.
So another question, like the couple of people have asked the same thing for, that was HER2 positive we did in the first session, that, like the role of HER2 expression, the level of HER2 expression, like we have in endocrine. We have hormone receptor positivity, so correlates directly with the degree of positivity. In HER2 as well, now there is data coming up and heterogeneity of the tumor. So like in your clinical practice, do you put any emphasis on that, Shaina? Or,
So a patient
and
is either
TDM1 not working in with, yes.
patient is, as of now, with the data that we have and the FDA approvals, a patient is either is positive with a HER2/3+ or a FISH positive disease. And that's it. That's where you use your anti-HER2 therapy. Yes, there is emerging data looking at trastuzumab deruxtecan in those patients with low HER2, but I'm quite skeptical about that data, I have to admit. I think it's the payload that is probably driving some of the responses that we're seeing with that with the trastuzumab deruxtecan in the patients with HER2 low expressors. I mean, Azmina, you've asked about different agents that you can use in triple negative. I use sacituzumab is very expensive. It's extra. If my patient can afford it, I will use it. It has amazing data that was presented at ESMO with a huge PFS benefit of 7 months, which I thought was really spectacular. But what is sacituzumab? It's an antibody drug conjugate that's using something that targets TROP2. You could use irinotecan. It's a cheap drug that we've been using for colorectal cancers for years, and we have old data, not very old data, but old data, looking at irinotecan in breast cancer, and it works. And I have many patients who've got triple negative breast cancer where I will use irinotecan single agent because they cannot afford sacituzumab, and they respond and they do very, very well. So you can find alternatives.
Yes.
I absolutely agree with you. We're using a lot of irinotecan because we can't afford this.
Yeah, I think that, so that's very, like positive note for a depressing metastatic triple negative breast cancer. So with that, I'm getting signals from everybody that you've exceeded the time. Third, I would like to thank each one of you, please, for your time. I know Zeba's battery has died. She pre-warned me, so she's excused. So Dr. Pervez, Professor Grobner, it was lovely to hear your talks. And Shaheen, of course, she is, we'll be seeing each other very soon. But really enjoyed the session, and I'm already getting a lot of feedback saying that people have learned a lot. So thank you very much, and hopefully next year we will see you all here in Lahore, and we'll take you around. We'll paint the town red.
Thank you.
Thank you.
Thank you.
Great session. Thank you.
Take care.
Bye-bye.
Bye.
Bye. See you soon.
Bye.